News Talk 590 WVLK and on FM 97.3. We have my friend, Dr. Kevin Kavanagh. And, Kevin, I haven't seen you in a while, but we sure do read you all the time.
Well, thank you very much,
in
sir.
the Lexington Herald. You're in there all the time.
Well, now and then. I try to write some good op-eds on healthcare policy.
Yeah, and you also founded an organization called Health Watch, right, USA?
Yes.
Tell us about that.
Well, it's a nonprofit organization, approximately 50 members. It's actually nationwide right now.
Is it really?
Yeah. We've got from Alaska to Maine down to Texas. We have a board of directors. And we've been quite active in healthcare policy, and this has mainly evolved around antibiotic-resistant organisms. But we're also quite interested in and been active in reducing adverse events or patient harm which can occur in hospitals. And so we've been looking at policy on a national level for those two problems.
Yeah, wonderful. This morning we're going to start, and we'll go as far as we can with the time we have, with resistant bacteria that you say is an epidemic in our country, including things like MRSA. Now, you only care about this if you've got a loved one that's had it. But as soon as you have a loved one that's had it, it's a big deal. And C. diff and all those things, they can take your life.
That's correct.
Yeah.
And things are not getting better. The United States missed 4 out of 5 of the goals for controlling these infections in 2013. We are not on track for reducing these infections for either C. difficile, for MRSA, or for the nightmare bacteria, CRE. These are all very scary. If you look at worldwide, this is a huge problem. By 2050, we're looking at 10 million deaths worldwide. This will outstrip the deaths from cancer, and $100 trillion being spent. So this has the potential of breaking our healthcare system, let alone...
Not to mention the deaths.
Yeah, let alone the untold death and disability that it's causing on patients.
What's causing it?
Well, I think that you've got two things. One is antibiotic overutilization, which is huge. Antibiotics are one of the #1 causes of resistance. Obviously, you're not going to become resistant unless you're exposed to the antibiotic. And data shows that Kentucky is in the bullseye of antibiotic usage. If you look at a map of Medicare data for 2016, Kentucky is just totally red, and then after that it gets kind of pink and then fades out. So we do like our antibiotics. So as you know, in the bullseye for opioid usage. The other cause has to do with the control, and this has been something we've also been very active in. Health Watch was one of the driving forces behind the regulation for reporting bacteria in Kentucky, which has derived a lot of data, especially on the spread of CRE, which is that nightmare GI bacteria that has close to a 50% fatality rate when it gets in the bloodstream, and it's virtually untreatable. So that is a huge problem, is how do we prevent these infections even though people are colonized?
Are all these mainly hospital-acquired or acquired at medical facilities?
Many are, but not all hospital infections are multi-resistant, although many are. And you're now getting these bacteria into the community and are coming in, and especially CRE, this very deadly bacteria. MRSA is almost endemic in the community. In other words, there's probably a rate of 2 to 4% carriage rate in the community. Probably close to 4 to 5% of healthcare workers are carrying this now.
Wow.
And so we feel quite strongly that screening and identification of workers and patients that may be carrying some of these agents needs to be done, and then having them decolonized. And this will help prevent infections.
Can you carry it without having symptoms?
Definitely. Well, that's what a carrier is. And
a carrier doesn't have symptoms. Okay.
Yeah, and actually that's what makes these more deadly than, for example, Ebola. Ebola breaks out. A lot of people get very sick. Their carrier rate's not huge. And so thereby you can identify those that are infected and get them under care or treatment or isolated. But with these type of bacteria, there's a significant number of patients and individuals that just carry them. And they essentially spread and make other people sick up until the point when their immune system gets weakened and then they become sick.
I see. Well, I tell you what I'm going to do. I'm taking a break. And then when we come back, we're going to open our phone lines. And we're back with Dr. Kevin Kavanagh. And we have a question online here from our text line. Do you have data on the local hospitals regarding infection rates?
Yes, we do.
Are they shocking? How do we do generally in the Lexington Hospital?
Generally, the hospitals, the latest data from Hospital Compare, on some of the infections, they're average. On MRSA, there's definitely some hospitals that are not doing as well. Central Baptist tends to be the best. Of course, that's Baptist Health Lexington currently, and they have a better than average rates, for example, of control of MRSA. University of Kentucky, well, not so much. They've got some work to do, but nevertheless, these rates are on Hospital Compare, and people should go and check them.
Hospital Compare.
Hospital Compare, yes.
Okay. Now, MRSA, is that the most common of these bacteria?
Well,
resistant?
that and C. difficile.
Okay.
Some of the facilities have been able to lower the MRSA rates, such as the VA system. They've had a phenomenal decrease in their rates of MRSA infection, over 80%. But when you look at C. difficile, all of the facilities are kind of struggling with how to decrease that type of infection, because it does require a lot of antibiotic stewardship to prevent these spores from activating. Now, that means you've got the spore to begin with. But if you take a lot of antibiotics or even a little antibiotics, these spores can activate and get infection. So antibiotic stewardship is very, very important with this.
Once MRSA or C. diff or even this horrible CRE is in your system, does it always remain there?
Well, MRSA does not, but
okay.
C. difficile can, because it can hide into a spore, which is like a little fortress, and antibiotics can't penetrate it. It can stay around for months and months and months, and then approximately 20 to 30% of patients, these spores will reactivate and you get a recurrence of the C. difficile. That's why it's such a tough infection to fight.
Is it the lack of cleanliness in the facility? What causes it?
Well, it's hard to tell. I kind of think, and we've had numerous publications on this, that a lot of it has to do with tainted research and how to control these organisms. And we published on chlorhexidine bathing, which is an antiseptic, where some hospitals and facilities will bathe every patient in a ward every day in this chlorhexidine, try to prevent MRSA. And the research this is based upon, we feel, was tainted, primarily relates back to one study, reduced MRSA study. And there have been numerous articles now that are advocating this protocol because of this research, which we do not think is up to par. There was a large Reuters investigative report. If you Google Deborah Nelson, Reuters, MRSA, you'll pull up this report, and we're part of it, that looked into the industrial conflicts of interest, which had to do in the millions of dollars that were behind some of the researchers that were involved in the study. So yeah, it was a huge expose, and it also went into some of the federal agencies with approval of the drug, etc. And it is non-FDA approved for this usage. And this is something that's still being advocated by segments of the medical profession. When I say non-FDA approved, it's actually FDA disapproved. They say do not use it for this.
Really?
It did not work in the lead author's hospital in an outbreak in the neonatal unit of MRSA. And the lead author of the article reported at the Infectious Disease Convention in San Diego that on reanalysis and reinvestigation, it's only primarily works into patients that have medical devices. So the whole study, unfortunately, I think is tainted. The results aren't good, but it's still being used by a large number of facilities. And they should be doing what the VA is doing, the Veterans Administration of Surveillance, isolation, and the VA system, as I said, has had a marked reduction in rates. The United Kingdom, same experience. They went to surveillance and isolation, 70% decrease in MRSA infections.
Here's a good question from our text line. It says, is there any kind of CRE registry where hospitals can access and quickly ID someone who may have CRE?
No.
That's a shame.
Yeah. Well, the tracking system's pathetic in the United States. And we had another article we wrote about this on MRSA prevention, and that's been quite highly read, and this was last year, which actually showed that if you use the data on MRSA bloodstream infections, the rates were going up. And that caused quite a stir because I don't think too many people looked at that data before we did, and all sorts of reasons of why it may be going up. One was it's because they changed how we measured community-acquired MRSA, and that's when we found out that the federal data on MRSA in hospitals is down adjusted if there's a high rate of MRSA in the community. which we don't think is appropriate. There's a lot of how you adjust data. And so you can't even compare, for example, the MRSA data from the VA system, which tracks all infections, to the private system, which just does bloodstream infections. And there's nothing for CRE. There's no mandated infections for CRE. I mean, if there are carriers, they need to be identified. You need to do epidemiological contacts. Anybody who got in association with that person needs to be tested, and isolation and treatment needs to be instituted. And
where did CRE come from?
Well, it came strictly from the medical profession, antibiotic overutilization.
That's it.
And I think now some people say, well, it's agriculture. They do use this colistin, which is polymyxin, which can be used to treat CRE. That's the only antibiotic left, highly toxic, but they use that in agriculture in China, but they don't in the United States. And unfortunately, and I pointed this out at one of the federal meetings, is that polymyxin is in almost everybody's medicine cabinet. It's over the counter in the United States.
What's it called?
Polymyxin B. It's triple antibiotic ointment polysporin. And
really?
yeah. And if you're going to control anything, and you're talking about antibiotic overutilization, I feel that the first step would be reformulating these products. Yes, it's low dosage, but low dosage is what causes resistance. And I think that's where some of the outbreaks, at least in the United States, is coming. Colistin is so toxic, it's not overly utilized in the healthcare profession. And some of these CRE cases that are just popping up in the environment in the United States, I think look in the medicine cabinet. That's what I would suggest doing.
We're talking about hospitals mainly, but how about nursing homes, doctors' offices, clinics, that kind of thing?
Nursing homes are a huge problem. Whether it's the hospital or the nursing home, they point the finger at each other. And that's one of the reasons why you need a coordinated approach. You need health department involvement for these infections to get control of them. And that's one of the big things that the regulation that Steve Beshear enacted at the end of his administration does. It requires all these infections to be reported from all types of facilities with health department engagement. And as we talked about at the break, we've already seen some fruits of this, with at least 2 reports in the CDC magazine describing some unique spread of CRE, and it's adding to the knowledge on how to control these organisms. And to me, I think it's hats off to Steve Beshear for doing this.
Okay. For the future, we only have about 3 minutes left. Anything that looks, I mean, this all sounds pretty dismal.
It's dismal.
Is
yes.
anything happening that gives us reason for hope of this thing getting better? I know that people go in because we as patients expect to get a prescription for an antibiotic because we've been trained somehow to ask for that. And do doctors have to just say, nope, it's not going to help you, it's going to hurt you, I'm not going to give it to you? How do you deal with it?
Yeah, that is starting to occur, and people need to become educated. I had 2 inappropriate antibiotic prescriptions recently, and 2 of my family members. One received Cipro, which is floxacillin for an uncomplicated urinary tract infection, which was absolutely not indicated. And the other one received Zithromax for an upper respiratory tract infection. Zithromax that's a Z-Pack. Zithromax, there's a lot of concern about that because of fostering antibiotic resistance. Unfortunately, at least with my insurance, that's the one that just cost a couple of dollars to get, as opposed to the $10, $20, $30, $40 prescriptions. Yeah. But we don't want to develop these resistant bacteria. And certainly you do not want to take antibiotics when you do not have to. They can cause significant complications, but they can also activate C. difficile. So you can actually get a worse bacterial infection from taking an antibiotic than the one that you thought you were treating for, which may have been just a viral URI or cold that would evaporate on its own in a couple of days.
And sometimes we get these prescriptions and we get better in a couple of days, so we give the prescription the credit when if we hadn't had the prescription, we also would have gotten better in a couple of days, right?
And that's true. And you know, when I was a physician, I would see that all the time. But I took a lot of undue credit. Of course, I took a lot of undue blame, too. Sure, I'll be honest with you. But I think that people really need to cut back on prescriptions, especially in Kentucky. Take them only when they have to. And be very careful of the antibiotic that's prescribing. If you're prescribed a fluoroquinolone or Floxin, Cipro, really raise up the red flag and say, do I need this? They're associated with tendon ruptures, hallucinations, depression, and some of the psychological effects can be or have been reported to be permanent. So those are last line antibiotics for severe gram-negative infections.
So when you go to the doctor, instead of doing what we've done up to this point and saying, will you give me an antibiotic, if the doctor wants to give you an antibiotic, you need to say, are you sure I really need this?
That's correct. What you should be saying is, I want to get my throat cultured or screened. And yes, that test isn't 100% accurate, but the chances of you getting a problem from a missed throat culture, which can be severe, is probably less than the chances of getting C. difficile. I know a lot more patients that develop C. difficile from antibiotic usage that they probably didn't need than myocarditis from a strep infection.
Can you hang with us for another 15 minutes? I think you might be interested in what my next guest has to say.
Sure.
And may have a comment or two.